Thank you, Professor Tanwandee, for your kind introduction. Good morning, ladies and gentlemen. First of all, I'd like to thank the organizers for the invitation and also for JGHFoundation for selecting me for this prestigious lectureship. Here are my disclosures. So this is really my great honor and pleasure to be here today, particularly to speak after my mentor, Professor Joseph Song. So if you do not know, I'm actually the last clinical fellow accepted by him before he stepped up to be the president of our university. So beyond that, I also have many mentors and teachers along the way. So in particular, Professor Francis Chan, Professor Henry Chan. So as you can see, in this GI family, we also have a number of surgeons here. So this is not to say that they are under the Department of Medicine, but just to say that in the Chinese university, we have had a long tradition of clinicians and surgeons working together to advance the field. So I'm very proud to be in this family. So for the younger people in the audience, Professor Kunio Okuda is really the pioneer in our field. So he established the world-famous liver cancer group in the Chiba University School of Medicine. On top of that, he was also the president of ISO and APASO, and he also served as the associate editor of hepatology, as well as the chief editor of the Journal of Gastroenterology and Hepatology. When I went through the list of lecturers for this prestigious lectureship, I realized a number of things. So first of all, I have had a personal interaction with almost all of the lecturers before. So they taught me along the way, and I would call them my teachers, and if possible, my friends. So in particular, Professor Henry Chan was one of the lecturers, and he was my mentor in hepatology. And Professor Anna Locke, he was the mentor of Professor Henry Chan, so he would be my grandmother. Okay, so I was asked to talk about the past, present, and future of fatty liver disease. So let me bring you as far as possible in the past. So this is the Chibanian and Gelasian period, so around 750,000 to 40,000 years ago. So we have Neanderthals during that period. So these are ancient humans who overlapped a bit with our Homo sapiens. So they resided in Europe, Western, and Central Asia. Why am I talking to you about that? Let's ponder one question. Did they have fatty liver? Okay, we will never know because there is no tissue remaining of these individuals. But what we know from a gut paper earlier this year is that if we look at the PNPLA3 mutation, that is the most robust genetic predisposition for fatty liver disease. So very interestingly, when the investigators looked into the sequences of more than 10,000 ancient and modern humans, they found that 100% of Neanderthals actually carried the PNPLA3 mutation, which would increase the risk of fatty liver disease. So it turns out that energy or nutrition abundance is a very recent thing in the history of humans. So in fact, in the bigger history of humankind, we were always in starvation or at least uncertain food abundance. And therefore, because fat would contain more than twice the amount of energy compared with carbohydrates and proteins, so it would actually be of evolutionary advantage to be able to store fat in the liver and elsewhere in the body. So this also begs us the question of whether we are adapted to the older world and whether we are when we are facing with energy abundance, whether our body is not as adaptive. Okay, when I started my career in around the year 2000, so fatty liver was not a popular topic. So in fact, you hardly found anyone in the Asia-Pacific region building a career on this topic. So at that time, it was not called MASLD or MASLD, it was called non-alcoholic fatty liver disease. It was considered unimportant, so many clinicians, when they see a radiology report of fatty liver, they would simply tell the patient, this is unimportant, I have never seen patients developing complications arising from NAFLD. So endocrinologists would tell you that this is hepatic manifestation of the metabolic syndrome. But what they really mean is that it is just the hepatic manifestation and nothing more. There's no treatment, and if there is any treatment, the management is the same as for obesity and metabolic disorders. So there's no point studying this disorder. But a quarter of the century later, people have changed their minds. So it is now known that it is the most common chronic liver disease worldwide. So more than 30% of the global adult population has fatty liver. And it has also emerged as one of the leading causes of cirrhosis and liver cancer worldwide, so mostly in the Western world. In Asia, we haven't come to that part yet, but emerging data suggests that the trend is certainly there. We have a new name for the disease. We have built a clinical care pathway for this condition. And finally, we are starting to have active and exciting drug development programs for this condition. Now, fatty liver did not start with NAFLD. So in fact, long ago in the 19th century, it was first identified by Thomas Edison as fatty liver arising from people with excessive alcohol consumption. It was not until the 1970s that hepatologists start to report similar pathology in people who have obesity-related disorders. It was only in 1980 when Dr. Ludwig and colleagues from the Mayo Clinic first coined the word non-alcoholic steatohepatitis. So somehow this term got hold, and people started to use the term non-alcoholic fatty liver disease in the next 40 years. Until in the year 2020, Professor Aslam and also Professor Jacob George, along with investigators in Asia Pacific and Europe, proposed to change the name from NAFLD to metabolic dysfunction-associated fatty liver disease. So this has attracted a lot of attention, but also there were some pushbacks. So some people think that this change is immature and not discussed among different stakeholders. And therefore, the American and also European liver associations convened another Delphi process and then finally landed on the term metabolic dysfunction-associated steatotic liver disease. So the main reason for the change is because some patient representatives also found the term fatty stigmatizing, and that's why steatotic. Now, at this point, I also want to give credit to Professor Jeff Farrell, who unfortunately cannot be with us today. So around 10 years ago, we published the Asia Pacific Working Party on NAFLD management. So at that time, he personally wrote one of the statements saying that we should have a positive definition for NAFLD. So I quote him, he said that NAFLD is a form of fatty liver disease that can reasonably be attributed to overnutrition and its complications. So at that time, frankly speaking, I didn't know why he wrote that, so, but it was retained in the document and nonetheless. So it was until many years later when Professor Jacob George first proposed the NAFLD term, did I fully understand the rationale behind. So for many a time, we have been diagnosing NAFLD using a negative criteria just as a diagnosis of exclusion. This is inappropriate because this is the most common disease and it shouldn't be a diagnosis of exclusion, but rather it should be based on the known pathophysiology, and the term should reflect that. Now, since there was some proposals for a change in nomenclature, so unfortunately, there was some tension among international societies regarding this. So to me, this shouldn't be the case. So in hepatology, we long have the history of collaboration and also friendship. So we shouldn't be pointing fingers and say that one term is the correct one and the other is inappropriate. So we should treat each other with respect and understand each other's perspectives. Now, in terms of stigmatization, I have 2 points to make. So first of all, together with the Global NASH Council, many of us here have contributed to these international surveys. So in fact, if you ask the patients, the stigmatization really did not come from the term fatty liver, nor non-alcoholic in the first place. So rather, they think that the majority of the stigmatization came from obesity and how people treated obese individuals. And on top of that, I would say that changing the terminology is never the final answer to eliminate stigmatization if we do not treat people with respect. So for example, if you take this example, on the right-hand side, we have witnessed changes in terminology from mental retardation, mental handicap, intellectual disability. So every time when people proposed a change, it was out of goodwill. So they want to reduce stigmatization. However, think about it. So if you change the term and then children still laugh at other children with intellectual disability, this would become a new stigmatizing term. And a few years later, you have to think about another term to replace that. So instead of keep changing the terms, we should create a society that is inclusive and acceptance. And to do so, this would do the biggest benefit to our patients. Now, the other big development in our field is the introduction and validation of different non-invasive tests for the management of MASLD. So I think this group should be very proud. So in the Asia-Pacific region, we have contributed significantly to the development and validation of various non-invasive tests. Now, to many people, the use of biomarkers or non-invasive tests would be for diagnostic purpose. So you diagnose fatty liver, you diagnose fibrosis. However, actually, there are more uses to diagnosis alone. So we can use it for prognostic purpose. So we also do not see the patient one time, but repeatedly. And therefore, those should be considered as monitoring tool as well. So we should be able to tell our patients whether the disease is improving or deteriorating. And finally, we also need to use it as a response biomarker. In other words, you should treat the patient and then do the biomarker to see whether the patient is improving. Now, the last point is particularly difficult because in order to establish a response biomarker, you need to have effective treatment first. But for a very long time, we didn't have that. So it is only in recent years that we start to work on response biomarkers. So we need to check all the boxes until we can say that, yes, now the non-invasive test can be considered as a surrogate endpoint even in clinical trials and also to be used in routine practice. So I would say that we have already got overwhelming evidence to show that many of these non-invasive tests are good for diagnostic and prognostic purposes. However, in terms of monitoring and also response detection, we still have work to do. So in the past few years, one of the things that we have been doing would be to establish the VCT prognosis cohort. So this is a multi-center cohort involving patients from the United States, from Europe, and also many Asian Pacific countries. So we included more than 16,000 individuals, so many of them with data collected prospectively. And over a follow-up of 4 to 5 years, we gathered more than 300 liver-related complications, so including liver cancer, cirrhotic complications, liver transplantation, and liver-related death. And therefore, compared with many of the historical studies, this one would have the sample size and also event rate for us to validate different non-invasive tests. So I'm particularly happy that this is led by many young investigators. So highlighted here would be Dr. Huapeng Lin, Dr. Hei-Wen Lee, and also Dr. Terry Yip. So I'm particularly proud that this is a platform for many young investigators to interrogate the data and also answer important questions. So on the right-hand side would be the data from our first publications. So we firmly established that many of our non-invasive tests would be better or at least as good as liver histology in predicting future liver-related events. So in particular, the VCTE-based agile scores, so measuring liver stiffness along with other clinical factors, would be better than liver histology in predicting those outcomes. So it indicates that if you only want to predict whether a patient is going to have complications, you really do not need to perform a liver biopsy to answer that. So another major contribution of this cohort is that we not only looked at the non-invasive test at baseline, but also looked into its change over time. So this is the diagram indicating the change of liver stiffness versus the change in the risk of liver complications. And the right-hand side, you can see that a 30% change either way, so 30% increase or 30% reduction in liver stiffness would translate into significant improvement or deterioration in the risk of liver complications. And therefore, it establishes liver stiffness measurement by VCTE as a monitoring tool. However, we have to remind ourselves that fatty liver is quite unlike many other chronic liver disease. So you would believe that for autoimmune liver disease or genetic liver disease, the majority of patients would be seen by hepatologists. But it is not the same for fatty liver disease. So in fact, the vast majority of patients will be in the hands of primary care physicians and also in specialists of other specialties like endocrinologists, cardiologists, etc. And therefore, when we talk about non-invasive tests or clinical care pathway, we have to ask ourselves, what do they have access to? So it is no point talking about very fancy biomarkers that they cannot order. So in that case, this is not doing a service to the field. And therefore, the American Gastroenterology Association established the first clinical care pathway for people with fatty liver disease. And I was very honored to be part of this program. So essentially, there are a few key concepts. The first is that we have to liaise between primary care and also hepatology practices. We need to identify patient at risk. So the first step is actually not to perform a biomarker, but to identify people at risk of having fatty liver disease. So including those with obesity, type 2 diabetes, and multiple cardiometabolic risk factors. Then we perform a test that is accessible in primary care. So what we propose would be something as simple as a simple fibrosis score, like the fibrosis-4 index. It is only when the FIB-4 index is abnormal would we recommend a second-line test. It can be VCTE, it can be a blood-based biomarker, such as enhanced liver fibrosis score. But the bottom line is that we need it to be practical. And I'm very happy that after the publication of this proposal, many other professional societies have followed suit. So now we have a more or less aligned clinical care pathway recommended not only by APASL, but also by European, American societies, and even diabetes and endocrine societies to manage people with fatty liver disease. So using the VCTE prognosis cohort again, so Dr. Terry Yip in the audience validated the two-step approach. So it has shown to be also prognostic. This shouldn't surprise you because if FIB-4 index is prognostic, VCT is prognostic, of course the two-step approach is also prognostic. However, we have two other key findings. So first of all, if we use the two-step approach for prognostication, the performance is actually as good as performing VCTE on every patient. So this approach is actually cost-effective. And secondly, if you have already performed FIB-4 index, the second step can be just FibroScan examination. You do not need to use a composite score with liver stiffness measurement plus other clinical parameters. This is because there is significant overlap between the FIB-4 index and other fibrosis scores. And therefore, if you have already performed FIB-4, you can keep it simple. None of the things I have mentioned would be meaningful if no one is doing it in their clinical practice. So to me, this is difficult because for primary care physicians, they do not just take care of fatty liver disease. They have to take care of many things. And therefore, fatty liver may not always be one of their priorities. You can always run a clinical study with them and then do it more consistently. But if you want to roll it out to the broader community, this would be more challenging. So to me, there are only two possible solutions. The first would be to make it part of the routine. So for example, if you do diabetes complication screening, you incorporate fatty liver and liver fibrosis assessment as part of the assessment. So this can be done. The other possibility would be to do it as an automatic system. So in order to answer that, we did a randomized control trial to test an automated system. So in essence, half of the patients would be randomized to have the FIB-4 index automatically calculated based on the existing blood test. And then if the result is abnormal, whenever a clinician logs into the computer system to see a patient, there would be a reminder message to indicate that the patient has abnormal fibrosis score and more actions need to be taken. So this is a collaboration RCT done together with Professor Hua Keng Chan's group in Malaysia. So we did it at 5 primary care and also diabetes clinics. We enrolled more than 1,000 individuals and then did the RCT. On the right-hand side, you can see the top-line result. So essentially, we can increase the rate of referral or the further ordering of a second-line test in people with abnormal FIB4 from 3% to 33%. So this is a more than 10-fold increment in the proportion of patients receiving proper care. But of course, this is a glass half empty situations. You can see that still more than half of the patients, despite abnormal FIB4, despite computer prompting, our primary care physicians or diabetologists still didn't act on the system. So we still need to refine the system to see how we can do better. Now, in terms of management, I should remind everybody that lifestyle management would still be the cornerstone for the management of fatty liver disease. So in particular, the degree of weight reduction matters. So in particular, if someone can lose more than 10% of the body weight, there would be resolution of MASH and also fibrosis improvement. Sadly, it is easier said than done. More than 10% of weight reduction can only be achieved in 10 to 20% of individuals, even in clinical trials. So in the real world, it would be considerably less, and even fewer individuals would be able to maintain the lifestyle in the long run. And therefore, some patients would need to have pharmacological treatment nonetheless. So we now have 2 registered drugs for the treatment of at-risk MASH. So the first would be resmetirom, and the other would be semaglutide, a GLP-1 receptor agonist. Another major development is a class of drugs called FGF21 analogs. So this is a hormonal agent, so it has been shown to have potent anti-fibrotic effect, as shown by 3 different drugs by 3 different companies, all showing an anti-fibrotic effect. And at 2 years, we even see that fibrosis regression can occur in up to 75% of cases. And even in patients with biopsy-proven cirrhosis, by 2 years, some of them can achieve reversal of cirrhosis. So this is a landmark in hepatology. So in no other previous studies could we reverse MASH cirrhosis in that way. So this is a breakthrough. So we now have a backbone for treatment. So we have incretin therapy, including GLP-1 receptor agonists, to take care of the metabolic side. We have FGF21 to take care of the fibrosis. And we also have many other targets to treat patients with MASH. But of course, this is not the end of the story. As researchers, we always need to identify the edge and see how we can do better. We need to be able to select the right drug to the right patient and to determine what to do when the non-invasive tests are not working and whether we should use combination therapy. From the patient side, we need to consider accessibility and affordability, long-term safety, and also, importantly, cirrhosis is the biggest unmet need. So how do we do that? So the future is here. So we already know that there are different subtypes of fatty liver disease. So for a very long time, there are conflicting studies to say that fatty liver is associated with one condition, and some other studies would say that it doesn't, because this is too superficial, too rudimentary. So hepatic steatosis is just a biological phenomenon from many causes. In different patients, the causes can be different. And therefore, if we look closely, there are different subtypes. So this is a major publication in Nature Medicine telling us that if you do clustering analysis, you can roughly divide the patients into several subtypes. To the least, there would be a hepatic subtype and a cardiovascular subtype with differing outcomes. So some would be more prone to develop liver complications. Some would develop cardiovascular outcomes. They may die from myocardial infarction before they would have a chance to develop any liver complications. AI is also in prime time. So in Nature last month, we hear that there is an AI tool that can predict more than 1,000 diseases as good as or even better than many of the models that we have already built in the past. So I would say that in terms of prediction of the future, we are remarkably bad. So many of the things that we predicted in the past did not materialize. We do not have flying cars, we do not have time travels. But at the same time, we have also built many things that people in the past never dreamed of. So instead of forcing ourselves to predict the future, we have to remember that most people underestimate what they can do in 10 years' time, but overestimate what they can do in 1 year time. So as long as we work closely together, we collaborate, eventually we can move the field forward and benefit our patients. I would also like to take this opportunity to thank my colleagues. So particularly in the hepatology field, I work closely with Professor Grace Wong, Terry Yip, and Jimmy Lai in the audience. And I'm also indebted to the collaborations and support from many of our regional and international collaborators. And with that, I thank you very much.